Welcome. My name is Brendan. I'm the COVID-19 lead for the Adelaide PHN. Firstly, I want to acknowledge the Kaurna people who are the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connection to land, waters, and community, enduring now as it has been throughout time. We pay respect to them, their culture, and their elders past and present. We would also like to acknowledge and pay our respects to those Aboriginal and Torres Strait Islander people from other nations who live, work, travel, and contribute on Kaurna country. Mani Ngā Padni, welcome. So, Adelaide and Country PHN, in conjunction with SA Health, are providing a COVID-19 update for primary healthcare providers. The webinar will be facilitated by Dr. Emily Kirkpatrick, Deputy Chief Medical Officer, and Dr. Melanie Smith, GP Liaison COVID-19 Projects and Operations in SA Health. Emily will provide a COVID update and discuss the COVID referral pathways for general practice for antiviral medication prescribing, the new model of care, and Healthdirect secure messaging changes for antivirals. Our guest speakers are Cara Kolompilic, clinical pharmacist from the Central Adelaide Local Health Network, will provide a presentation on tips, tricks, and practical advice on how to safely prescribe oral antivirals for your patients. We will be having an interactive poll for attendees, which will look at scenarios for those more difficult and complex cases. Cara will be supported by Jackie Yeo, GP Liaison Officer, and Deborah Rowett, Director of Drug and Therapeutics Information Services Data, for discussions for these scenarios. Our case-based discussions with our experts, experienced panel will with resources to make this a safe, efficient, and practical process for GPs and specialists. Presenters would very much appreciate webinar attendees putting cases they would like to address with the panel on the question and answer part below, not in the chat. Alternatively, raising your hand at the bottom of the screens at the end of the presentation or when discussing scenarios will enable you to voice your concern live. This webinar has also been accredited for Mega Points. I will now pass you over to Emily as we have a lot to go through this evening. So Emily, I'll pass it over to you.
Fabulous. Thank you, Brendan, and very warm welcome to everyone joining us tonight. We're very, very excited to have a comprehensive presentation, and particularly interactive, which I'm just so excited about, as having been running these webinars now for 2.5 years. This is the first time we've had an interactive webinar, so we finally caught up with the times, which is fabulous. Just before I do commence, I would like to acknowledge the land in which we're meeting here today and pay my respects to elders past, present, and emerging, and particularly pay my respects here on Kaurna land here in the SA Health building. Okay, so let's get started. I'm going to run initially through the primary care update, and as many of you know, I pull these slides often together very last minute so I can include the latest information to present to you. So I'm just going to share my screen and put them up so you can see. And acknowledging as well our fabulous group of presenters that we have here today. Mel Smith, who's the medical lead of our community and primary care partnerships in our high risk, overseeing the high risk hub as well. Dr. Jackie Yeo, medical lead of the COVID Care Centre. And then very pleasing that we have both Professor Deborah Rowett from Director of DARTIS, who we know has done a fabulous job, the DARTIS team being able to support so many GPs with prescribing antivirals. And then the fabulous Cara has come back to us from the Carlin COVID Care Centre, and some really, really practical tips and tricks we're going to go through tonight as to how we can get this prescribing up and running here in South Australia, higher volumes for our patients being prescribed here, and really understanding some of the complexities as well. I would encourage you to please post any questions you have into the Q&A box, and all of us on tonight's webinar will be able to respond. Please avoid posting in the chat, otherwise we do sometimes miss questions coming through. Okay, I'm just going to get started now. So again, just a timely reminder about Health Pathways. If you're not already connected with Health Pathways, both Adelaide and Country SA PHN, very easy to log in online, and you can utilise the COVID-19 username and the password being SA password. Very easy. And we are continuing to update that information so it's available and readily accessible by both GPs, practice nurses, and across the LHNs. So in terms of what's new, and I was thinking, what could we say that's new in this fortnight since we met on the 30th of June? And it's actually quite a bit. So increasing case numbers, I'm going to just cover very quickly. The new secure messaging that was launched on Monday for the notification of high-risk patients eligible for antivirals. I'm then going to step through the SA Health GP Respiratory Pathway, which is the expanded service delivery model of the GP respiratory clinics. I'm then going to touch on the close contact 28 days post-infection, so some of those changes that did come in over the last couple of days, the fourth dose expansion and expanded antiviral PBS criteria. So it's actually quite a bit, and we have been sending out quite a lot of information in the GP updates recently because there have been quite a number of changes to get your head around. So I'm going to start just with the COVID update of the numbers, and more so just to touch on where we are seeing some of the shift with PCRs and RATs as well. So we did have an increased case count today, and we were up to 4,408, and that does track along where we do see over the next 2 weeks an increasing number of cases here in the state. And that's really consistent with other states as well, where we are seeing now that increase in cases of BA5, particularly driving those case numbers. Yesterday, we did see our RAT numbers were well above our PCR numbers, but today pretty much on par with PCR and RATs. And a reminder as well, if you have a patient who calls you up and said, did my RAT this morning, not sure what to do, you can actually now report on behalf of that patient, which is fabulous. So previously, it was only the individual themselves had to log in online, fill in the details, but you now can report on behalf of others. Same thing, you can report on behalf of your children, parents perhaps that are unable to use devices, and also for patients as well. So we've tried to make it really easy to be able to report on behalf of others, just so we can get the most reliable information through. And we do require, as part of the Public Health Act, reporting within 24 hours if you do test positive on a RAT test. No requirement at all for PCR testing. To report that in is an automatic notification through to the CDCB team. So you can see the hospitalisation data is relatively stable over the last couple of days at 245, 6 within the ICU, and we are seeing again a significant increase in the number of PCR tests being undertaken. And a reminder as well, ACL and ClinPath do now require a referral form for testing at their sites, and we do expect that we're going to see a bit of a drop off in the number of sites they are operating as well. But the SA Pathology, SA Health sites do still have that no referral test available, and we have seen an expansion again of services across regional South Australia to meet the current demand. So in terms of our case numbers and hospitalisation numbers, and this is data from yesterday, we can see an increase in cases coming through, and again increasing hospitalisation numbers, but stable for the last couple of days, which is good. If we look here at overall active cases, you can see we're really now starting to head into this third peak here in the state. We had a little blip back in May, but looking like we're tracking along the modelling data up to that around about 5,000 to 6,000 cases in the next couple of weeks. And that really does depend as well on where we see changes as well at the end of school holidays. There's been a bit of talk that we've heard about what does it mean about the school holidays? Are we expecting on the Monday post-school holidays to see an increase in cases? But it's really just going to be dependent on where we see some of those numbers tracking and making sure that we get people tested and encouraging testing where possible so that isolation can be followed. This is the RA modelling. As you know, I present this each time, and very, very grateful to Joe Barney at the Royal Adelaide in the ICU department, who does pull together this data. And this is based on internal numbers and really just helpful from a hospital occupancy perspective to see where those numbers are tracking. And we are tracking along that higher number, particularly for hospitalisation. But pleasing to see that is trending where we would expect it to be at this point in time. Just in terms of Healthdirect data that we have currently, so Healthdirect as the National Coronavirus Helpline, that's the #1 way that patients get access to healthcare currently, other than calling you as their usual GP. And we have noticed an increase in calls. We had 421 calls that came through the National Coronavirus Helpline on the 11th of July. So just increasing there. And we have noted as well that we are seeing a relatively stable number of clinical escalations to our high-risk team. Now, our high-risk team is the team of GPs being led by Dr. Jenny Gould, who are now working within SA Health in our high-risk hub to be able to manage patients who have additional complexities And also, that's the team who are answering calls coming through our medical COVID information line. So if you do have any inquiries and you call that GP number, that's the team that you will come through to. And they're an amazingly helpful team who know how to navigate the system, get drugs into patients, and access into COVID care centres. Final thing I just want to show here is we do get a daily report back in from the NCH, particularly around triage categories. So remembering it's a nurse-led assessment, I think people think, oh, I'll just call the helpline and they'll tell me what to do. But in fact, it's the nursing team who do that assessment who then triage the patient to the most appropriate level of care, low, medium, high risk, or in that urgent severe category to call 000. And our team, the high risk hub, operates 7 days a week, 8 a.m. to 8 p.m. Now, just in terms of this week's genomic data, and of course, we do like to reflect on where we are currently, we are now seeing that increase in BA5, particularly more so than BA4, which is certainly tracking expected with the eastern states as well. So we're on par at the moment between BA2 and BA5. And remembering as well, as I say, with this genomic data, we don't have Tom Dodd anymore to give the update here. Remembering the genomic data, it is a very, very small sample size that does have genomics undertaken here in the state. So it is important for us to really look what's happening in overseas and interstate jurisdictions to try and track and see where those numbers are presenting. Critically, though, the genomic data is looked at for hospitalisation and hospital patients as well. And we're not seeing particularly that there's a favouring towards BA5 in those patients who are unwell within our acute system. So that's good news. In terms of the overall data that SA Path have provided through this week for us, and this tracks the number of cases, just gives you that percentage breakdown from the previous graph that I showed, where we're sitting at that exactly 23 cases for BA2 and BA5 on the genomic sampling this week. And we expect that we'll get a better picture, particularly in the next week or two when there's more specimens running through the lab. And because I couldn't help myself, I've had to put an influenza chart in here. And this was because we saw that drop off in last week's data. And this is the publicly available report that comes out online. We had that drop off and then increase. Again, a reminder, if you are ordering influenza tests on your patients, you do need to report in and notify through to CDCB, either on the purple form or online, to advise that the patient has tested positive for influenza A or B. And the reason for that is the lab does not automatically notify this data through to CDCB. So that data that we show on the screen is dependent on GP notification. So I just wanted to provide a timely reminder in case I think we've all come into the space where we're just used to an automatic notification with those referral forms of COVID, but it is important that you do notify through to CDCB for influenza, particularly for this data. Otherwise, we'll see drop-offs in numbers and think, oh, that doesn't make sense. So very important for the team there to have that. Okay, so let's reset and move through those key areas I just wanted to update on. And again, a reminder about the new service model, and this launched on Monday, so just 2 days ago. And what it involves is any patient that tests positive for COVID-19 can call up the National Coronavirus Helpline, have that triage assessment with the nursing team there. And now, this is the new added fantastic feature. They send secure messaging now to the usual GP, to the patient who's calling up that NCH number. They can send a secure message to that practice to notify that they have tested positive. I know we've been going on about this for many months, let's get GP notifications on the pathology forms. Well, fantastic news now that this is how notification is occurring for those high-risk individuals through secure messaging. Not only that, but the team at the National Coronavirus Helpline will also call up just to notify that the reception staff and say, look, we've just sent through a notification. They won't provide any further details, and there's no expectation for that practice to contact the patient. It is up to the patient to still call the practice directly to say, yes, I've tested positive, I was told to give you a call, and we're hopeful that you'll be able to fit them in within a time frame that allows them to receive medication within that 5-day period. So that's the change that came in on Monday. Now, if the patient says, to the NCH, I don't have a usual GP, I can't remember who my GP is, the team at Healthdirect can send off a notification to 1 or 2 practices, depending on who they're able to identify there. And second of all, as well, they do have your updated details through the online Healthdirect forms online. So if you have had a change in practice, just make sure you are up to date on Healthdirect. But they've been doing a lot of work in the background with practices, making sure those details are up to date, specifically so we can get the secure messaging right. The final step, though, if someone doesn't have a practice, there are some GP respiratory clinics who have agreed to accept patients for oral antiviral therapy. And we had 3 patients today who took up that option, who called NCH and then were referred into one of the GP respiratory clinics. So please encourage your patients and, and really just remind reception staff as well. If a patient calls up, they're not certain what to do, they're in this uncertain period, they don't know whether they're eligible or not, they can call up that NCH number and they'll be able to risk assess whether the patient meets the new PBS criteria, which we're coming to. And these slides, of course, as usual, are available at a later date, and this is available online on the PHN website, and we link to this on Monday's GP update. Now, SA Health GP respiratory pathway, what we do know is around about 11% of ED presentations are for respiratory reasons. So what we've tried to do is look to see where we can create greater capacity in primary care to support patients who are presenting to ED who don't really need to necessarily be there, but were unable to go and see their usual GP. And so what we've done is with the PHNs, we've put additional resources into the GP respiratory clinics, the 4 metro GP respiratory clinics, to create a pathway for respiratory illnesses that are not necessarily COVID. And reminder of it as well here that the Commonwealth funds the GP respiratory clinics for COVID, so we're funding them for other respiratory conditions. So for ear aches, influenza, sinusitis, trying to make it as easy as possible for patients in the community to get a face-to-face assessment. And it was grateful to be able to go out and have a look again at the setup at Paraka and see what's being established at the North Eastern Respiratory Clinic and where they have expanded their existing GP capacity now to offer a 7-day service. And we look forward to the other sites as well being able to expand out based on workforce. So if you are interested, we have sent out the details in Monday's update. Please get in contact with the sites. We'd absolutely love to have more GPs on board at these GPRCs. Reminder as well that patients don't need a Medicare card. We've been asked about family members that come from overseas, for instance, don't have a Medicare card. They can be seen at these sites. There is no MBS associated. It's a direct funding arrangement with the Commonwealth. Now, reinfection period. Oh, I've got something on my slide there. In terms of the updated reinfection period, we did release new advice yesterday online, and we have had this go out a social media post as well. But the window for potential reinfection for COVID-19 has been now changed officially in the CDNA song from 12 weeks down to 28 days. And that's because of the cases that have been re-emerging and particularly that reinfection being detected. So what it does mean now, if you're a close contact and it's been more than 28 days since you've had COVID-19, you're required now to follow the same close contact requirements we have in place for someone who's not been exposed to COVID-19. So that means that you need to follow the testing requirements, do the 5 RAT tests, undertake a PCR test if you're going back into general practice, get that negative test, and then you can go back to work with PPE. Now, if you are though in that 28-day period and you develop symptoms during that 28-day period, the advice we have here is that if you're in a high risk group, do you then go and undertake a GP assessment? So going into one of the GP respiratory clinics advising patients, or having a telehealth consultation with one of your patients in this space. And it may be in that criteria that you organise then to have another test, and specifically maybe looking for influenza in someone who may be eligible for Tamiflu, for instance, but just in that high risk group. Then after the 28 days, if anyone develops symptoms, they must go and get that COVID-19 test. Plus you may find that they may benefit from an influenza test depending on their risk factors. So this has all now been updated online. I hope that makes sense. But we do know this is going to add additional pressure to the workforce, particularly now that we've lost that 8 weeks interval where it was, we thought really that was giving that really good hybrid level of immunity. 4th dose expansion, just a reminder here that we have had that 4th dose expansion that was announced on Friday, came into effect on Monday, and that means now anyone over the age of 30 can get that 4th booster dose. It does need a 3-month interval from the last COVID-19 infection or 3 months from last COVID-19 infection as well. So it's not moved to a 28-day period. There's no 28-day interval between an infection and a 4th dose vaccine. It's still a 3-month interval to ensure optimal immune response. The other criteria, of course, here has been the fact that we are encouraging as much as possible individuals aged 50 to 65 now to take up that 4th dose. And there's no expected mandatory requirements to come into place here. We have had a few inquiries whether we expect there'll be a healthcare worker mandate for 4th dose. There is absolutely no discussion of that occurring at this point in time. It is all about trying to boost the level of immunity in the community we have, keep those hospital numbers low as possible, and making sure we can reduce the severity of symptoms. And a very, very big thank you to all of you on Monday morning who put up with patients calling into your practices, who set up additional clinics, who've ordered in additional Pfizer stock and Moderna stock over the past week, so that you can now respond and help your patients navigate this new change. And we have had today the West Parkland site open up, which we expect will be operational for the next month or so. On Friday, we have the Maya Centre site opening, and we do have the Elizabeth GP Plus site in the north as well. So important that patients know there's still the SA Health sites, but of course pharmacies and GPs that have stock and have availability are other options as well. And finally, expanded PBS criteria, which is what we're all here tonight about, is about oral antiviral prescribing. We have had that new criteria, and particularly the over 70 criteria now that's coming with the PBS, regardless of symptoms, but you've got the COVID positive result now being eligible for oral antiviral treatment, which of course has seen a sudden surge in demand on our stocks here in the state, which are somewhat depleted in community pharmacy, as many of you may be aware. There is the Pharmacy Guild webpage, which does point towards community stock of oral antiviral treatment, and we did put that out in the GP update, but we are aware it can be difficult at the moment to navigate and try and find stock for your patients. So if you do have concerns, please call into our GP medical advice line and we can help navigate and find stock for you. So I feel like that's enough now at 23 minutes in providing where we're up to currently with our COVID response here in the community. And now I'm going to hand over, and don't forget, post your questions in the Q&A box. I'm now going to hand over to Cara. We're looking forward to your presentation this evening on oral antiviral treatment. Thanks, Cara.
Thank you, Emily. Hi, everyone. Let me share my screen. I don't think I've seen you guys since before Paxlovid went on the PBS. Time's a bit of an illusion for me at the moment, though, so I could be wrong with that too. Let me see. All right, those slides coming up okay?
Perfect.
Beautiful. Yes, so prescribing Paxlovid. The last time I saw you guys, as I said, was probably back in April, so pre-Paxlovid being listed on the PBS. So there have been some changes since then, even within the last week, the last fortnight, as Emily so rightly said. So we'll be going through some prescribing tips, some tricks for the real world, some clinical scenarios. We've got lots of example questions and scenarios at the end of this to help give you a better idea of what you can do in multiple different situations and circumstances. And we'll obviously be doing Q&A with some cases that you guys bring as well. So just a little bit of background to get everyone back up to speed. Paxlovid is still the first line antiviral treatment for mild COVID disease for everyone, unless there is a contraindication. So Paxlovid is still first line. The rationale is Paxlovid is more effective than molnupiravir, which is the other oral antiviral agent. Remdesivir, which is the IV option, is also more effective than molnupiravir. So you've got Paxlovid and Remdesivir being more efficacious than molnupiravir. However, molnupiravir has that better safety and tolerability profile compared to both of those agents, especially in regards to things like drug interactions. So it's really a trade-off between efficacy and safety and tolerability, it can be very difficult. There's also some real-world data about the oral antivirals that's now available, and I've hyperlinked an article there that links to, there's some Israeli and Hong Kong data. It's very interesting, but it just proves those initial pilot trials that they do work. And exactly like Emily said, COVID information is always changing. I wrote these slides on Friday and then woke up to a barrage of texts on Sunday saying, oh, we've got to change, we've got to do it all over again. So that's the old PBS criteria there. As of this Monday just gone, this is the new PBS criteria. So I will spend a little bit of time going through it more than I originally planned because of how recent the change is. But essentially, the age restrictions. So previously it was above 65 with 2 risk factors or above 75 with 1 risk factor. Now it's just if you have a patient that's COVID positive within 5 days of symptom onset, that's 70 years of age or above, doesn't matter their risk factors or vaccination status, they will qualify for oral antivirals. So that's the big difference there. That'll include a lot more people who will be eligible for these medicines. The second group, the 65 years and above with 2 risk factors, that age has decreased quite significantly to 50 years and above and 2 risk factors. And very similarly with the Aboriginal and Torres Strait Islander population, it's dropped from 50 years and 2 risk factors down to above 30 years and 2 risk factors. I've also put in green some of the PBS risk factors that have been added or changed. So like demyelinating conditions, COPD and moderate to severe asthma has been broadened and generalized to respiratory compromise. Heart failure, the NYHA restriction has been removed, and coronary artery disease or ischemic heart disease and cardiomyopathies have been added. So again, including more and more people into those inclusion criteria. And as you can see, age and vaccination status has been removed for all age brackets there as a risk factor. With the second streamline authority for Paxlovid, the above 18 years of age and moderately to severely immunocompromised, some minor changes. The biggest one you might notice is there's no minimum dose for methotrexate or azathioprine required anymore. Essentially, they're pretty much the same, but there's one change I've highlighted down there as well. And just quickly, if you've gone, all right, I know these changes have happened, but every time I check the PBS website, it still says the old criteria, that will continue until August. So these changes here are in effect now, as of this Monday just gone. However, the PBS website prescribing software, streamline codes, etc., won't be updated until August 1st. So you can prescribe based on the new criteria. Absolutely go for it. Get more people onto these oral antivirals. But the websites and the publications and documentation at the moment won't be changed for another, 2 weeks. So you got your patient in front of you, or telehealth, I should say. You're thinking about starting Paxlovid or the oral antivirals. Contraindications, these are the same as last time, and I feel free to refer to my previous PHN presentation for more in-depth information about the orals in terms of contraindications, safety, efficacy data. This is just skimming over it so we can go into the actual prescribing examples. But less than 12 years of age, that's something that's different from 3 months ago. Less than 40 kilos, pregnancy or breastfeeding, that's the same. Inability to swallow the tablets whole, cognitive impairment, or severe renal or hepatic impairment, they're all the same there. So these are the contraindications that still apply for Paxlovid. So you got your patient, yes, they qualify on the PBS, on this fantastic new PBS criteria. There's no contraindications that you can find on this slide. So what do we do now? This is when you check for your drug interactions. This is what takes up a lot of the time. This is why I still have a job. So drug interactions, this, if you've seen the state guidelines, the SA Health guidelines on the treatment and referral website, you'll know what this looks like. This is adapted from the Liverpool COVID-19 drug interaction checker. And you can find similar tables in all the different sorts of guidelines, but this is the one we use. So if you ever hear myself, another pharmacist, or COVID doctor talking about red box or green box interactions, this is the information we're referring to here. This is just a zoom in of those red box interactions. And the red box, it's a bit counterintuitive because there are some of these red box interactions that are absolute no-nos. You cannot give Paxlovid if your patient is taking these medicines. And I've put those no exceptions, do not use together here on this slide. And I've just bolded the ones that I see most often. That's not to say you won't see the other ones, but all the medicines on this slide here, I want to be clear, you cannot give your patient Paxlovid if they are on a medicine on this list concurrently. These are the absolute contraindications. The good news about this is if you know your patient's on this, it's a very easy decision. You go to the next treatment option. You don't even have to think about working around Paxlovid because you know you can't give it. So that's the first sort of half of the red box drug interactions with Paxlovid. The second sort of half of this is there are some red box interactions that are sometimes okay to give with people on those medicines, and we'll go through each sort of class in a bit more detail now. So the first one, anticoagulants. Before you dive into, I can just hold it or I can just do this, I want you to think about what's the indication for this anticoagulation. Why are they on it? What's the risk of stopping therapy? Is it a high risk reason? Is it a lower risk reason? If they're on warfarin, can I monitor the INR more frequently, or can I get someone to do that? Would they be able to self-administer or have someone at home that can administer enoxaparin if we changed over? So these are the things we should be thinking about with anticoagulation. And I've made up a little table here that is hopefully clear. It just summarises the information that's on a few different drug interaction checkers in regards to the agent, the interaction colour, to try and keep it consistent again across different interaction checkers, the effect that Paxlovid will have on the medicine, and then the strategy. So, for example, warfarin's actually an orange interaction. The INR levels and the warfarin exposure in the body can increase or decrease, and so you can change someone to enoxaparin for the 8 days, or you can continue warfarin and do INR monitoring every day or every second day. And I've done both strategies, just depending on the patient and the resources we had available. Then there's something like rivaroxaban, which is absolute no-no. But again, we have that option of changing to enoxaparin for 8 days because we know enoxaparin is a green interaction. So we can hold rivaroxaban and bridge with enoxaparin. You can also hold some of these anticoagulants if you think the risk is low enough, but there are a few cases that or indications I would be comfortable with holding completely without bridging. They do exist, but they're less common, and it gets a bit risky there. But I've got some of the examples that you can do there. And for apixaban and dabigatran, you can actually sometimes decrease the dose depending on the patient's indication, and also things like renal function and original dose. Antiplatelets, another big one that we see very commonly. Again, what's the indication? Is this primary or secondary prevention? If it is secondary prevention, what's the event history? How severe was the previous event? How long ago was it? The classic example I see is someone who's had a TIA 15, 20 years ago, as opposed to someone who's had, multi-vessel stenting within the last year. Those are very, very different risks of reocclusion or reinfarction compared to each other, and it will direct what I do with their antiplatelet therapy. So aspirin is green, good old aspirin. We're happy to use it with Paxlovid. Clopidogrel is orange, and this is interesting because it's a prodrug, so the levels are reduced. So if you think that the reduced clopidogrel antiplatelet effect is safe or acceptable, then you can give it concurrently. And ticagrelor is an absolute no-no. And hopefully you don't have someone inappropriately on ticagrelor. So this is usually a case where you have to think about something other than Paxlovid. Antihypertensives, big one, big issue with Paxlovid. We see a lot of people on these. I've never seen so many people on amlodipine before. Lecanidipine is obviously the big red box one. You cannot use lecanidipine with Paxlovid. I think it's something like the Paxlovid increases exposure by 15 times. So the risk of severe hypotension and ADR risk is exceptionally high. So the only option is to hold. Now, that is something that can be done. If your patient in front of you has had really stable blood pressure, they run on the lower side anyway, lower systolic side, it might be okay to hold that lecanidipine for 8 days. It might be even more possible, especially if they have a blood pressure monitor at home. If you can get them to monitor their blood pressure at least twice a day, if you think they have the capacity to, report back their blood pressure or track it or escalate if it goes above, 180 systolic, that is a very possible solution. It's something we do a lot here in the COVID Care Centre. The same with amlodipine, felodipine, the other CCBs, dutazim, verapamil. We do know their levels will be increased with Paxlovid exposure, and so their effect will also increase. And we can safely either hold or half the dose a lot of the time, even continue at some lower doses if we're confident the patient can monitor their blood pressure and monitor for those increased hypotension or bradycardia risks. So that is another option too. And for the most part, beta blockers are green. There are some that do have some increased exposure, the hepatically cleared ones like carvedilol, metoprolol, bisoprolol. So if you've got someone who's borderline bradycardic already, that's who I'd be worried about. For the most part though, beta blockers are green, and ACE inhibitors and statins are green as well, green interactions. Statins, simvastatin is the red box. Again, exceptionally high exposure levels when Paxlovid is on board. So the risk of severe rhabdo is much, much higher. It can be very serious. So the only option is to hold. Again, is it primary or secondary prevention? If I've got an 80-year-old on 20 milligrams simvastatin at night for primary prevention, I am very happy to hold that drug for 8 days. Same with atorvastatin and rosuvastatin. If it's primary prevention, I'm very happy to hold for 8 days. Secondary prevention, again, it depends on how recent the event was, the severity, if they've had multiple infarcts, things like that. But usually if it's greater than 3 to 6 months, I'm a little bit more conservative and usually say a year, but I'm happy to hold those for 8 days usually. Or you can decrease atorvastatin and rosuvastatin to just 10 milligrams a day if we really needed to keep that statin therapy on board for the 8 days. The other red box medicines that can sometimes be safely adjusted to facilitate Paxlovid use are listed here. Colchizine's a big one. I've seen people go, oh, they have to have remdesivir because they're on colchicine, and you're asking, it's PRN for gout flares and they haven't had it for 3 months. I'm very happy for that patient to have Paxlovid and just be counselled on, if you do get a gout flare, I don't want you to take the colchicine. This is what I want you to do instead. Diazepam is a tough one. There's a lot of diazepam use in the community, both regular and on a when needed basis. If it's PRN and it's relatively seldom use and someone is confident they cannot take it for 8 days, I'm happy for Paxlovid to be prescribed for that patient. If someone's on it regularly, or you're unsure the accuracy of how often or infrequently they're taking it, I'd be less confident in giving Paxlovid. It's the same with domperidone, sildenafil, tadalafil, vardenafil. If it's PRN, when required use, it's fine. Tell them not to use it for 8 days. If it's for something like gastroparesis with domperidone or PAH with the PDE5 inhibitors, that's something you can't use together. The one I've highlighted, the salmeterol there, that again depends on their underlying respiratory condition. So if they've got really severe asthma or COPD, really crumbly, I would recommend, instead of holding it for 8 days, swapping to another agent. So they've got some, LAMA, LABA, and corticosteroid on board. But if you've got someone who just uses it when needed, their asthma or COPD is quite well controlled, some people can get away with holding it for 8 days as well. And of course, supplements. I just have the blanket rule, hold all your supplements. It's just easier, especially in people who take a lot. But the main ones we're concerned about are the ones that can collate and bind in the gut, such as calcium, zinc, iron, and then herbal supplements and preparations that can affect potentially liver function and enzymes like that. So we've already mentioned the sort of red box interactions in terms of antihypertensives, the salmeterol and statins, and in all honesty, they're probably like above 50% of what we see. Most patients have at least one, if not more, of these medication combinations there. So that's what we see the most in terms of Paxlovid drug interactions. What I haven't mentioned yet are some of the other ones. Hydroxychloroquine that we see often. Hydroxychloroquine, the risk is increased risk of QTc prolongation. So you can decrease the dose or hold it for 8 days, depending on what dose they're already on, what they're using it for, if their specialist has an opinion on what to do with it as well. Digoxin, Paxlovid can increase digoxin levels and thus affect, so monitor heart rate and risk of toxicity. If they're on a lower dose, got good renal function and a good resting heart rate, I'm usually okay to continue. Again, if they've got slightly bradycardic already, got borderline renal function, that's when I'd be going, what can we do here? And combination tablets, this is also another big population I see. Dual antihypertensives, even triple antihypertensives, or dual lipid lowering agents in those combination products. You don't always have to write a prescription for the agent that doesn't interact. So the ACE inhibitor, for example, and then stop the CCB. You can get creative. You can half the tablet, you can take 1 tablet every second day, you can hold it and then the patient monitors their blood pressure, and depending on what it is, the patient can take another antihypertensive, a single agent, a half of the combination. You can get very creative with this, and there's no right or wrong answer. It's what your patient in front of you can manage and what's appropriate for them. So I've come up with any and every strategy for antihypertensives and how to work around these interactions. So you can get very creative with your solutions for this. And with the dual lipid lowering agents, it's often just easier to say to hold it, because sometimes they'll get confused what agents what, especially if they've had it split before. So I usually just say to hold it, but you can continue some of them, especially if they've got, the fluvastatin or pravastatin in them. The less common interactions, some antidepressants and some antipsychotics, except obviously clozapine and quetiapine are known red box interactions. Most of the antidepressants and antipsychotics, besides the two already mentioned, you have to check each individual agent, but usually you can continue at the regular dose. I usually just counsel on, if you notice you're feeling a bit more anxious or sedated or whatever, the side effect profile of that drug is, just to say, if you notice this, it's from the Paxlovid, let us know. But usually you can continue at the same dose. And then opioids is the other big one. There are some, like codeine, where the effect is reduced because it's a prodrug, and then ones like oxycodone where the effect is increased. So again, counselling on, you may notice your pain relief is less well controlled, or you're more drowsy, whatever it may be, counselling on that. You might need some slight dose adjustments with opioids, but again, check the individual agent. So those are the most common ones we see, in all honesty. Everything else that's a bit more creative and a bit less common, we still have to look up. So don't feel bad about that. So what if my patient's Paxlovid drug interactions cannot be mitigated? I cannot come up with a strategy that this patient can help or can facilitate or comply with. What do I do? The drug interactions are too risky. What's next? I need another agent. Low risk patients, the argument can be made that molnupiravir may be appropriate for some low-risk patients who have contraindications to Paxlovid that can't be mitigated, and who would probably not qualify for remdesivir because they're not high risk enough. So molnupiravir may be appropriate for some of your patients, and that's okay. For your moderate to higher risk patients, that's when we would encourage you to refer for remdesivir, the IV agent, via the SA Health pathway. So that's when they come into a CCC or equivalent and get their IV remdesivir instead. So I've just come up with a little list here of the patients I would consider referring for remdesivir. I'm sure there is more that I've missed, but high risk immunosuppressed patients, or their comorbid polypharmacy, but they've got a contraindicated drug interaction, like they're on amiodarone and apixaban, but they've got all these other risk factors. That's someone I would want to come in for remdesivir, or transplant patients who are on tacrolimus or cyclosporin, automatically contraindicated for Paxlovid. Those are the ones I want to get in for remdesivir. Pregnant or breastfeeding, they qualify for remdesivir. They can get, pregnant and breastfeeding persons can get remdesivir safely and effectively. So refer those ones in. Day 6 or day 7. So obviously PBS requirements and even our guideline requirements say up to day 5 is when you can start the orals. Remdesivir can be given on day 6 and day 7 too. So if you've got someone who's just missed the cutoff, but they would otherwise qualify for orals, it's just the day, then you can send those patients in for remdesivir as well, or put the referral in, I should say. And then also patients without Medicare or PBS access. So overseas travellers, international students, things like that, they can get their treatment in a COVID care centre or equivalent. Obviously not having to pay full price for the agents because they are quite expensive. So summary, Paxlovid prescribing is possible. I know it doesn't seem like it sometimes, but it is. Look for the contraindications or the red box drug interactions first. It's honestly what I do. If I know someone can't swallow, or if I know someone's on amiodarone, it's easy. I go, we have to think about something else. We can't do Paxlovid. So look for the contraindications or those red box drug interactions first. It'll cut out who you need to move on for therapy for a lot quicker. As I've already said multiple times, you can get really creative with your solutions to mitigate a lot of these drug interactions. There's obviously the absolute no-nos with some of those red box drug interactions, but a lot of them, as I've shown on those slides and those tables, you can actually get pretty creative with. Make a plan ahead of time for your complex patients. If you know you've got someone on antiplatelets, anticoagulants, on 15 plus medicines, make a plan for them, because when they're COVID positive, you don't want to be sitting there going, oh no, what do I do? And then it takes so much time, there's so much stress on you. So make a plan if you can. And make friends with a local community pharmacy. I know, like Emily said, there's a bit of a stock issue now that everyone's wanting to prescribe it with the PBS changes, but that will be mitigated in a few days to short weeks. But Find a local community pharmacy near your clinic, near your centre. See if they can have Paxlovid on the shelf for you. See if you can come to an agreement or an arrangement with them, and that way you can facilitate Paxlovid supply more quickly and efficiently, as opposed to trying to find a new community pharmacy each time you have a patient being prescribed these medicines. And obviously a lot of community pharmacies can deliver, so reach out to your community pharmacy colleagues, see what you can organise there. And we are in a better place than 3 months ago. I know it feels like doom and gloom sometimes, but we've had a lot of time to become familiar with these drugs. They've been on the PBS for over 2 months now. More patients now qualify on the PBS with this expanded criteria this week. More community pharmacies stock the treatments. The oral agents are now listed in a lot more resources. That was a big problem, even 3 months ago. And there are more drug interaction checkers available, one of which Deb actually helped make, and I do have it here. The Veterans Mate Paxlovid drug interaction checker, which I've hyperlinked, and I'll send these slides out so you can use these links, is also free to use. It's an excellent resource. Obviously the gold standard as well, University of Liverpool drug interaction checker. As I've said previously, I like up to date, but you can use Stockley's, MIMS, whatever you can get your hands on in terms of drug interaction checkers. And I've just also listed some other prescriber resources on this slide here. As always, patient resources, there are heaps out there. These are the ones that I like using, and I've also hyperlinked them there for you. Always make sure your patients go with some consumer information, or your pharmacies can supply them as well. And now this is the big part. Any questions? I don't know if we want to do questions first or just get straight into the polling.
Thanks, Cara. I think we might do some of the question and answers. I think Deborah was going to answer one live. Deborah, do you want to answer that one live, the question and answer?
I wasn't, I don't think I was actually, Brendan. So I think we might go to the poll. I think I might have ticked the wrong box when I was doing the live one, but I'll come back to that after the poll, Cara.
I think, is that the one where can patients get COVID treatments twice?
Yes, that's the one.
Yes.
Yeah.
I can touch on it in terms of a medication point of view, not the decision about the 28 days, but the way I like to think about it is it's like an antibiotic, in that if someone has the same infection twice, they can get the same antibiotic twice. We're not restricted based on the unfortunate fact that they've gotten COVID twice. That's just bad luck sometimes. So these patients can get treatment a second time, and we've just started to see a few patients come through, and Jackie can back me up, where we've seen them in March, April, and given them Paxlovid, and we've seen them again in the last week or two where we've given them Paxlovid for a second time. So we are starting to see those patients come through. Obviously it will change in terms of who can get it because of that reduced time from 12 weeks to 4 weeks. And that is something that I'm sure our infectious diseases team will, get the finer details on. But in terms of restriction, there is no restriction in terms of if you've had it once, you can have it again. There's no restriction that you can only have it once in your lifetime.
And I suppose it was also, Jackie, you'd already posted the comments in there around that, if they have a reinfection within 28 days and involving ID.
Absolutely. It's tricky. It's really tricky at the moment. So much of this just completely evidence-free, and we're still making it up as we go along, I'm afraid. But we're not making it up. We're basically first principle rather than data. And, when you've got a renal transplant recipient, or ocrelizumab is the other big one, and I can't remember the name of that particular class, so I'm going to ask you two lovely pharmacists to tell me what those are called, those particular immunosuppressants, because Renji used a term today that I completely slipped out of my head. Anyway, that particular group are more of a problem.
All right, I might start some polls then. So hopefully this works. All right, hopefully something's popped up. Antiviral scenario 1. And hopefully everyone can select an answer.
While we're waiting, Cara, I'm just going to answer, there are a couple of questions about pregnancy and pregnancy alone. Is that sufficient for antivirals?
Go for it.
And the answer is no. You have to have a risk factor. And ideally, I think that's one that would be involving the patient's obstetrician or the treating hospital. And the DARTIS team would certainly take it to ID, and rightly so. I think they're complicated.
All right. You got 5 seconds if you haven't. I'm going to give a minute.
No pressure, Cara. No pressure. The other thing, I'll shut up for a moment. Answer that one first.
No. Yeah. All right. So first question, well done. The majority have selected the correct answer, which is C. So yep, carbamazepine, that's an easy one. If I see someone on carbamazepine, I go, next option. We don't have to go any further. So well done, everyone there. I did make it a little bit tricky because I said it was for trigeminal neuralgia and not epilepsy. So I did throw that in there. That is my bad, but well done. All right, Jackie, you can keep talking. I'll put the next one up.
The other thing that came up in the question and answers was around the renal cutoffs for antivirals. Now, molnupiravir, you don't have to worry about the EGFR. Paxlovid, yes, there's a dose adjustment. EGFR of more than 60, you can just give the normal dose. 30 to 60, we recommend halving the dose of nirmatrelvir. Under 30, not recommended to use Paxlovid. In theory, not recommended to use remdesivir. It's off-label, but we have successfully used it off-label in the COVID care centre on many a patient, but we always liaise with the treating nephrologist just for safety's sake.
This pulse thing is great. I love it. We've got to do this more often.
That's great. We finally managed to do it.
No, it's great. All right.
Fantastic. So we've got 47% participating in this one, but
Let's see. Well done again, everyone. This is I would classify this as a very high risk patient. Renal transplant, solid organ, stem cell. These are the ones that we would be saying send in for a remdesivir referral. So well done, great.
It's interesting, just incidentally, having seen a patient from Interstate earlier this week, I know that Interstate, they are doing all kinds of weird and wonderful things with tacrolimus levels and cyclosporin levels. All I can say is it's so much easier with remdesivir. And having seen a case of cyclosporin toxicity, I'm not keen to see it again.
And this is a tougher question, I will admit. This one's multiple choice, so there are a few answers for this one. So well done again, great guys. C would be my preferred answer, but B and E are also appropriate too, depending on what day of disease they are. If they're early on, if they're day one and you know they're going to go into day centre or have a telehealth appointment within the next few days with their specialist, that might be appropriate to not provide treatment. But for most patients, I would say C in this situation. But yeah, B, C and E, I think are very acceptable.
And that is exactly what we do, is we contact the oncologist, as do DARTIS, and have a conversation around what can safely be held and what can't. There was a question in the chat that I wanted to answer. Just a second. Antiviral resistance. Well, we haven't seen it yet, but who knows? Who knows? I don't even begin to know the answer to that one at the moment. And the other thing is, could you change to a second or third line antiviral if you've got nasty side effects from Paxlovid? And Cara, we have done that, but it sort of depends. I'll let you answer that one. I think
Yeah, it's a tough one because these are medicines that are $1,000 a box, so I don't like wasting them. If I can, they're very expensive to the state and federal governments. We can do it. I'm more inclined to do it if they absolutely cannot tolerate it and they've only had a day or less, basically, maybe 3 doses maximum of their first antiviral, and then they still have 4 days or 3.5 days to continue. Like I said, I don't like doing it and I don't recommend doing it, but for those high risk patients that really need antiviral therapy, we have done it.
we have, but there are also some nice little strategies that you can do. The bad taste is often the thing they don't like. And we've had some clever workarounds, spoonful of jam. One patient who got very excited, and I said, well, if you want to take donuts, that's okay. And rang up his daughter and said, right, okay, we're getting orders of donuts. Ice cream's another one that one of the oncology patients said she's used for bad taste. So the oncology patients are often very tolerant of it because they're used to bad taste. They get it all the time with chemo.
Yes, yeah, very true. Yeah, I've recommended jam in the mouth or honey as well on a spoon. Sometimes that helps with the metallic taste. This one, good job. This one was a bit harder. I would have recommended C, but I can see where people have come in and done A, and also for B as well. If you can't access remdesivir, B is okay, but you can actually hold the lecanidipine in a lot of the cases, especially if their blood pressure is stable and they are able to monitor it at home. So that was that one there. But yeah, good job so far, everyone. Let's put that one there. All right. I will touch on resistance very, very quickly. Yes, we don't know, which is not fun. No one likes not knowing. The Paxlovid, nirmatrelvir and ritonavir combination in the pilot trials, it was tested against all known coronaviruses, and it was effective, and resistance couldn't be induced in those pilot trials. So whether or not that changes with the different COVID variant changes, we will see. But I'm a little bit more confident with Paxlovid because it is so broad in terms of it's effective against all coronaviruses, not just COVID-19. But yeah, other than that, we don't know yet. I can't even remember my own question answers. I have to check that paper. So bad. So 6, I said D because this is for pericarditis. So I am not confident with holding colchicine. I would have a very angry cardiologist on the phone to me. So I would say D, but E I would also consider as well, definitely.
And interestingly enough, we have had a patient where they were on both colchicine and hydroxy.
That's right. I remember that patient.
Don't we all?
Was bad.
Don't we all? Yes, I think we're all involved in that one.
Oh gosh, yeah, that was a real team effort, that one.
Yes, and just for everybody online, because we couldn't safely hold either of those agents given the risk of pericarditis recurring. And of course, the risk is that with the COVID infection, the pericarditis could recur with that too. So it was a really tricky one. Most of them won't be as tricky as that.
And just while there's a bit of a pause, it's just to highlight that I suppose when you go to the PBS, yes, they come up on the list of immunosuppressives, as you said, Jackie, where you've got the JAK inhibitors, and not everyone maybe have the whole list of JAK inhibitors in their mind. And similarly, as you said, with ocrelizumab, don't necessarily think of that as an anti-CD20 antibody drug, for example. So that is, I know Mel has posted in the Q&A the SA Health mild treatment COVID guidelines, which has got a lot of those drugs listed by class, so that you can think of your ocrelizumab, how it fits the class.
We're all going to be pharmacists by the end of this, pharmacologists or pharmacists.
Are we showing our bias? Well done on question 7, everyone. That was, yeah, perfect answer. I would have agreed with that. I'm just looking while this other polls up. Run through renal adjustments for Paxlovid, remdesivir, and molnupiravir. So just what Jackie said before. So GFR above 60. Oh, Mel, the question's gone. But yeah, GFR above 60, normal dosing, nirmatrelvir 300 milligrams, GFR 30 to 60, nirmatrelvir 150 milligrams, GFR less than 30, Paxlovid or nirmatrelvir ritonavir not recommended. Now, if anyone has been having a little looky-loo, you will find a different answer on the Renal Drug Handbook. I do not recommend following that because it is not an evidence-based recommendation. It is a consensus recommendation. But all our guidelines here in Australia say don't use less than GFR of 30. Remdesivir, there's no dose adjustment. It just says contraindicated in GFR less than 30. But again, we've used that in dialysis patients, GFR less than 30. This is our oldest COVID drug. And so we have a lot more experience with it. Molnupiravir, that's the benefit. You don't need to adjust it no matter how well or poorly their kidneys, liver, anything works. So that's the one.
And Cara, just a shout out to you for the brilliant questions. Everyone's really enjoying them. So,
oh, thanks.
But we are needing probably a bit more time to work out our answers. I know I need to look at notes to come up with the answers.
I need to look at my own notes for this. Yeah, I know. I do apologize.
Your work is greatly appreciated. So thank you.
All right. Number 8, C. Yep, I completely agree. That's the one that I put in there as correct, so it must be. So yes, well done.
It's right. I'll agree with that one.
Thank you. I need the backup. It's been a long day. I don't trust my mind anymore.
Yeah, diazepam is actually one of the harder ones that we come across, and it's more common than we like to think. Speak of the devil, here it is again. You're obviously in a diazepam mood when you wrote these questions, Cara. Must have had a few in the CCC that day.
I've had a few today on the wards as well. It's been weird. Stage supply diazepam today. What is going on?
I think what's really nice is that I know it's taking time, but our audience are coming up with the right answer. And that's, I know the level C rebate going is a pain. And yes, we are trying very hard to do what we can with the proviso that, there are limited, it's difficult, but it's not being ignored. But even so, you guys are doing amazingly. You really are. So please be very encouraged by the fact that you're doing such a good job.
All right, 9, what did I put? B, yep, that's the one I did. And E as a second option as well. Yeah, so those were my two there. The reason I didn't say halve or hold is because this was a regular thing, and I tried to give the hint of they're on multiple antidepressants. So I was trying to edge you guys into the they maybe need to stay on it. But they're technically possible solutions. They might just not be the best solution for this patient, but technically possible answers.
So much of it depends on talking to the patient, what they're prepared to do. And I've been surprised, sometimes people will do things I didn't think they would, but diazepam, not great if you stop it suddenly, as we all know.
And again, it highlights, Cara, the small dose of amitriptyline that you had there. But again, it could be that there are multiple medicines where a small increase could predispose them to prolongation of the QT interval. And so again, it's sometimes looking at the combination together, which is important to consider as well.
Absolutely. That cumulative effect, I think that's what keeps us in business a lot of the time too. Yeah, anticholinergic, QTC prolonging, sedation, they're all cumulative risk factors or, adverse reactions from a lot of these medicines. So yeah, the cumulative risk, they all might be small doses, but if you all increase their exposure a little bit, it can all add up in the end. It's a very good point.
And especially given Jackie's point that these people have got COVID, and so therefore they've got other factors that might be contributing to cardiac issues that we need to be cognizant of as well in these people. So yeah, just thinking about the cumulative burden is a really important one.
The other thing that I think is worth keeping in mind, and I was just reading an article in News GP earlier this week that talked about how useful home medication reviews are and how much they decrease the chance of your patient ending up in the hospital with a really nasty, severe adverse effect, or if they do get into hospital, they get a better outcome. There's no reason, I would have thought, if you've got a patient who's on 5 or more medications or meets the criteria for a home medication review, that you couldn't preemptively do one and ask the pharmacist to consider what kind of medication you could prescribe and how you would handle Paxlovid ahead of time. Deb, please say if I'm, going out of line, but it's something that has occurred to me.
I suppose also, I know Mel has posted in the Q&A about the veteran mates materials, but the focus really was on, planning ahead, and Cara, you've highlighted that as well. And I think that's also important in residential aged care, that we do need to be thinking about planning ahead for those patients in residential aged care. And I know that's come up in the Q&A as well.
I'm going to jump in here and say there's a few people asking about side effects of both Paxlovid and Lagevrio. And I'm sure you guys can speak more to this, but there are a couple of great patient information sheets available on their Say Health website that talk about common side effects to expect. And I've been using those and emailing them out to patients when I prescribe. So that might be useful information there. There's also some good prescriber information sheets, which are probably nice to have on hand as a reminder. I'll put some links into some of the question and answer sections.
And also, Mel, just picking up some comments there by Eleanor, is that sometimes it could be that there might be another treatment option. So if they're using low dose diazepam for sedation, there might be consideration for temazepam or another treatment option as well. And so this is where it comes in terms of planning ahead. Maybe there will be something that that person can take instead of that drug that's likely to interact. But I think one of the things I'd like to highlight, and picking up your point, Jackie, around the home medicine reviews, is also that with so many people now that may be holding their amlodipine or having their lercanidipine ceased, is also then having a plan for when they need to restart. And having that follow-up that they have actually restarted. And also some drugs, it might be that they do experience side effects from restarting some of those medicines at the same dose that they stopped on, where they slowly had been titrated up to that dose. So I think that's where that review and follow-up is really important as well.
Yeah, very good points, Deb. In terms of I'll try and touch on a few things. The side effects, yes, the metallic taste or the taste changes is the most common with Paxlovid by far and away. I think it's about 6% incidence. Then diarrhea is 3%, and then nausea and vomiting is 1 to 2%. So those are the three we get called back about the most by far. So GI and taste changes. Exactly like Jackie said, you can work around it. A lot of the transplant hem-onc patients are used to taste changes. Even a lot of the room patients, high-dose pred, methotrexate, they can all cause those taste changes as well. So a lot of those patients will go, oh, I've already got that anyway. So those patient groups, you will usually be a little bit better, but it's not a harmful side effect, the metallic taste. Some people get really worried that, you know, they're dying, something's wrong. Why do I have this bitter taste or metallic taste in my mouth? It's not harmful. It's not dangerous. It's just annoying. And that's literally word for word what I tell people and that push through it. Use those workarounds we described earlier. In terms of molnupiravir, in all honesty, I don't get called back or patients calling me back saying I got this side effect. Maybe once in the last few months, but nothing compared to Paxlovid. The most common ones are that dizziness and GI upset again, like nausea and diarrhea, but I don't think it's anywhere near on the level as Paxlovid. And I'll just finish this poll and then go into remdesivir.
Yeah, I agree, Cara. And I think the other thing I find is if you warn them about ahead of time, they generally cope with it much better. So they're expecting that, you know, they might get a bad taste. And I tell them, I've got a lovely story about the lady who told me that it was like licking a Stovey pole. How she knew, I have to work out, although it may have been how she in the first place. But every time I tell that story, people laugh, and it kind of makes it much more normal and human. So you're welcome to use that story.
That's a good one.
I think also in terms of adverse effects, one of the things is unplanned pregnancies. So I think the counselling and contraception is really not to be underestimated and important as well.
Yes, I've never talked about babies and contraception as much as I have the last 6 months as someone who's not trained in that medicine. For this question, I just wanted to highlight though for question 12, I chose both C and D. I think they're both very viable options, but also B and E will also my orange, you know, second line choices as well. So this question is very difficult. So anywhere from B to E, I think is acceptable, but I would probably go D given the recency of the MI. But this is a good case, and we've had similar ones in Triple C.
Hey, Cara, I've got Carol, who is attendee, who's raised their hand. Carol, I'm just going to allow you to talk, and you should be able to talk now.
Just need to unmute Carol. It might be an accidental hand raise, maybe.
We have Mary as well. Oh, Claire. Well, I think people are accidentally doing it, but I've just got to say, if anyone wants to speak or speak to the panelists about any concerns or questions regarding antivirals, please do raise your hand, and I will allow you to talk to the panelists, and they'll be able to provide you some advice directly.
While this question's finishing, I'll quickly answer. The remdesivir you can get twice, similar to the other antivirals. We've had some that receive sotrovimab and then remdesivir, Paxlovid twice, remdesivir twice. So same principle. You can get it twice if it's a new infection and it is appropriate and, you know, discussed with ID. So you can get that twice as well.
And can I just answer the question, which is a really good one from Alison Edwards, from about the EGFR, if it wasn't available 12 months ago, you know, with the time period that needs to be. That depends very much on your patient. If you've got a fit, young, healthy, I don't know, 30-something-year-old, I'm not even too worried about having an EGFR. If there's no reason why their kidneys are going to be disastrous, then I'm actually quite happy to go ahead. If I've got an 87-year-old, I'd quite like to have something in the last few months because, you know, they're more crumbly. So it depends on the patient. But, you know, if you've got a reasonably fit, healthy patient who's not too old, I certainly don't mind using something that's over 6 months old. That actually is very reasonable. And sometimes I'll go without it at all. I hope that helps.
this question 13, I did a little pharmacy tricky as well and tried to push you guys onto B with all those medicines for her lungs or their lungs. Try to just emphasize how severe their respiratory disease was. So they probably, need to change from serotype to something else in the interim. But yeah, good job. And following on from what Jackie said while I get the next question up, just like I said last time, back in April, I think, if you can't get bloods or don't have bloods that day when you're ready to prescribe, you can take bloods and get the results the next day. Having Paxlovid at a higher dose for 24 hours, I would rather them have the treatment at a slightly higher dose and then you call them back and tell them the next day. So actually, don't take 3 tablets twice a day, take the 2 tablets twice a day. I would much rather that than they miss out on treatment or potentially get a less efficacious treatment like molnupiravir because we're just unsure about the renal function. I know it's hard, especially in rural areas. I don't want to sound like I'm not being sympathetic, but I don't want the default to be, oh, no GFR, just straight to molnupiravir. So that's the differentiation I just wanted to add on to what Jackie was saying there.
I'll also say sometimes you can be really lucky. And I had a patient last week I was able to, who didn't have an EGFR for some time and was a little bit concerned, but was able to start him on the drugs and then begged ClinPath to do a domiciliary visit. That's one of the benefits of being in Metro, is I actually went out the next day and did some blood so I could confirm renal function was fine and didn't need a dose adjustment. But I wasn't terribly worried if it did come back a little bit lower than it had been the previous year, because he would only have had 1 dose and would be okay to sort of pull back on following doses. So don't forget that there is the opportunity for domiciliary blood testing. ClinPath are willing to do that for COVID positive patients.
And good job again, guys. These are the 2 answers I had for this patient as well. So perfect, you're doing so well. I'm very impressed. And I saw something pop up, but yes, all my slides, the hyperlinks are active and accurate as of yesterday. So I'll send them out to Brendan, who can disseminate, and you'll be able to have those hyperlinks there as well.
I'm just going to answer a question that Eleanor Wilson put in the chat and asking how GPs can provide their patients with pulse oximeters. Emily, would I be right in saying that this could be a reason for referring to ICCNet? Would that be reasonable?
Yeah, absolutely, Jackie. And we've still got stock all in the LHNs as well for the pulse oximeters. We had about 15,000 at least that were in the stores that we had ordered for the community pathway. So there's both through that pathway. Then there was also a stock through the PHNs as well that we can send out to the respiratory clinics if that's helpful. So there's lots of options, and then ICCNet as well if you want them to have monitoring, someone to have monitoring as well.
And I think Belinda has her hand up. I don't know how to let her speak.
That's okay. Belinda, you should be able to speak now if you accept.
Thank you. I just wanted to back up what Mel was saying about getting EFRs. 2 really quick ways in general practice is to go onto My Health Record and look under pathology results. Often there'll be something they've been to CAS or into Emerge or something. And the other way, I'll just give a plug, is to use your IPAth access, because quite often people have had bloods on there that you may not have been CC'd into, and you can access all results for all patients on there if you have that IPAth access. And My Health Record is linked straight in general practice software, so there are 2 quick hints. Thank you. And this is awesome, Cara and team and Deb. It's fantastic. Thank you.
Thanks, Belinda. I'm just going to mute you back again.
Cara, we've just had a question about what MVR stands for. And
Yes, I did it for mitral valve replacement. I went for the higher, and it was the high risk.
it probably was, but I thought I'm going to answer this.
No, absolutely correct.
Yeah, very good point on abbreviations, though.
Agree.
Started on discharge summaries and all of the different. Yeah.
No, completely agree. We use too many abbreviations, unfortunately. 15, yep, perfect again, guys. These are the two answers I went for there. And this is something we've done with a few of our warfarin patients as well. Not possible for everyone. So in that case, E is also acceptable. But yeah, the first two, A and B, is what I would normally go for. I'll quickly answer while this other question's up. How much do these drugs cost to the community? So a community pharmacy has to buy in at the full price, so 1,023 or 32, whatever it is, for molnupiravir, and just over 1,100 for Paxlovid. And so there is a lot of risk for them holding the drug, because if they don't then dispense it out, they can't claim it back through the PBS. So that's why a lot of community pharmacies haven't been holding some of these drugs, because yeah, if they can't dispense it to someone, there is a high cost outlay there. Else, how many community pharmacies have it? At one point, mid-May, when we were sending out the daily list of community pharmacies who we knew had stock, probably 20 to 30, metro and a few more country. I have no affiliation with national pharmacies. I have never worked for them. I don't get paid for them, but I do find that they are able to order it in quicker, or they have stock on hand. And that's just from my experience the last few months, because they have their own supplier that is separate to Symbion and other suppliers that community pharmacies and even us in hospital use. They have their own private supplier of drugs. So again, I'm not getting paid by them. I have no affiliation or declaration with them. It's just what I've found, because they have their own individual supply chains. So national pharmacies tend to have stock on hand or able to order it in quicker. The stock shortages are temporary at the moment. So if a community pharmacy can't order it in today or the next day, it's usually within a few days, because there's not enough drug being made. It's just we're not able to get it out from the warehouses to the pharmacies quick enough, or we've gotten all the warehouse supply out, and so the warehouses need to be restocked before then the community pharmacies can be restocked, if that makes sense. So it's just more of an interruption as opposed to a true shortage. So hopefully you'll see that start to resolve soon. But yeah, like I said, make friends with a local community pharmacy. If you can say, I'm going to give you 5 Paxlovid a day, and have that agreement, they will be much more willing, as opposed to the random miscellaneous GP they've never had a script from calling and asking. So it's a symbiotic relationship sometimes. It's very difficult in community. I used to work there, but it can be done.
The other useful tool is the Guild's come up with a findapharmacy.com.au website, where you can,
I was going to say that,
you can look up who holds Lagevrio and Paxlovid. I think it's one of those things that sort of they have to sign up for it. And I think the manufacturers of Lagevrio now have their own site for helping people to find pharmacies that hold it in stock, but it requires the pharmacies to sign up for it. But it's another way you can try and find them. But I've been trying to get the patients to do all the phoning around while I'm busy doing the drug interaction checks, which is good for some, but doesn't work for others.
And we're getting quite a lot of calls, and we welcome those calls. It's been busy since it went more widespread. Mel, a lot of calls coming in from GPs via the 1-800 number, and also direct into Datas as well.
So question 16, this is another tough one. My answers would have been D or E, depending on your situation and the patient's situation, but A was also very acceptable as well. So yeah, I think A, D or E, all acceptable answers there, depending on what the patient can actually manage. If they can give enoxaparin, that is the one I would choose. If they couldn't, that's where I would go for D or E in that situation.
There's another great question from Alison Edwards, who I know works in rural, about if you can't get hold of Paxlovid, are you better off going with molnupiravir? And I guess that depends on the patient again. But sorry, small child doing things. Yeah, look, if it was a renal transplant patient, I'd so much rather they could get remdesivir. But if you can't get anything else, then molnupiravir is better than nothing. So you've got to be sensible about what's possible, and rural and remote can be hard, no question about it, Alison. So you do what you can for your patient. If that's the best option, you go molnupiravir. Absolutely.
There was also
there
was also a question in the chat about balancing the risks of side effects versus benefits, and I think it's really important to recognise that even though patients may not be unwell when they first present and ask for these antivirals, it's actually really important to prescribe them. And these are not medications to treat symptoms, and we shouldn't be waiting until patients are unwell to start them. And there's a lot of confusion about that out in the community. I know that particularly a lot of very stoic elderly patients are like, oh, I'm not sick, I don't need it. And it is really important that we prescribe these for people who are confirmed COVID positive as early in the illness as possible to stop them getting any symptoms at all. And that's partly why the PBS criteria have changed, so that if you're over 70, you actually don't need to have any symptoms at all. Prior to the recent change, you did have to have at least one recognised symptom of COVID. One of those was fatigue, so I'd be pretty impressed if anyone could be considered to not have any symptoms. But now it's quite explicit that a symptom or sign is not required if you're 70 years or older. So get it into people early. The benefits are huge.
Yeah, completely agree with what you've said, Mel. And we have a lot of patients that go, oh, I feel okay. Do I actually need it? And they feel like a burden, I don't need to be here, and that imposter syndrome. And it's about reiterating, you might feel good now, and I'm glad you do, but these are not to make you feel better right now. It's to stop you from getting worse. It's to stop you from getting sicker, and it's to reduce the risk of you ending up in hospital. And once you explain it like that and change that thinking of, this isn't a painkiller to stop pain or fever right now. This is something that's going to help prevent you getting sicker and ending up in hospital in the days to come. A lot of people are much more open to accept treatment. And in terms of the side effects of the orals, if anyone's been on a course of Omoxiclav, it's very similar. So a lot of people have been on some strong antibiotics. So the side effects in that respect, I would say the benefits of treating the COVID with these drugs would far outweigh the risks of the side effects, which a lot of these people would be getting, one, from their polypharmacy, or two, if they've had any course of antibiotics before. They have very similar side effect profiles in that respect, and obviously not including the taste changes, which are very unique to Paxlovid.
Yeah, completely agree. And I think of these medications as anti-ramping medications, because the reality is...
I can't hear you, Jackie. I don't know whether your hand's on your microphone on your computer, potentially.
Sorry about that. Is that better?
Much better.
Thank you. Okay. Yeah, I think of these as anti-ramping medications, because the more we get people in hospital with COVID that we then have to keep for longer because they've got more severe disease, the lower your chances of being able to get patients in, and they'd spend longer in ED and they spend longer in hospital. So it's good to prescribe them because it stops them ending up in ICU and it stops them ending up in hospital.
Very quickly, I've remembered a pharmacy, again, I have zero affiliation with. I should be getting paid, but I'm not. All the business I send to them. But for the Metro people, again, apologies for our regional staff in this, but the Terry White on Melbourne Street in North Adelaide, they have literally 30 boxes at all times of Paxlovid. They have huge amounts. They fluctuate between 20 to 30 boxes of stock on hand every day. They were the first community pharmacy in the state to get it in, besides the hospitals, and they have been some of our greatest friends in those early days, where they were the only pharmacy I knew of that had it, and it's continued to this day. They literally have dozens of boxes of Paxlovid there. So if you're in Metro, North Adelaide area, that is another option. I just saw the comment about the two national pharmacies not having stock. So they are usually my go-to if I'm desperate in the community setting. And in terms of interaction checkers that are most user-friendly, find one that you like using. Like I said, I like using UpToDate. and I like using the Liverpool with a pinch of salt. The Veterans Mates one that, you know, has just come out that Dab's spoken about already, that's really user friendly as well. I don't love MIMS and I don't love Stockley's, but I'll use it if I have to. If that's the only place that has the drug listed, I'll use it. So find one that you are familiar with, that you know how to use, and that has the drugs that you need in it, basically. There's no right or wrong one to use, although just be aware that different interaction checkers can sometimes have slightly different recommendations. The red box, the absolute contraindications will absolutely be the same, but some of those, you know, yellow, green, orangey ones, the lower risk interactions might have slightly different recommendations depending on what interaction checker you use.
And I suppose with the Liverpool one, you can print it out. Sometimes people just like to have a list of what doesn't interact as well. And then there's the Liverpool Interaction Checker app that some people like as well. So there are a variety. We use UpToDate quite a lot because of the increased number of medicines. And often if people are ringing us about them, they're ones that they haven't found easily. So we can access those as well.
Great job on this question as well. This was a tough one. I deliberately put the date of the TIA very far back because it should prompt to go, why are they still on DAPT anyway? It's something I see far too often. But yeah, D, B, or even E, I would have chosen there. All right, I think we've got 2 more questions. So thank you all for being so patient and participating so much.
And while people are answering that, one of the other things, I suppose, in terms of the counselling for patients is just a reminder, I know it goes without saying, but not to share these medicines with other people, and particularly the older age group who they might think they're doing the right thing by sharing it with their partner, spouse, family member. But again, because of the drug-drug interactions with Paxlovid, it's really important that they get that message not to share these medicines. I can see that wry smile, Mel, that, you know, but unfortunately people do share them, and I think that they will sit in the cupboard and people were thinking, you know, they might not have finished the course, and here you go, here's that that $1,000 medicine that we shouldn't waste. So again, it's an important message, I think.
And well done on this one. This was a nice, easy question. It's very easy to just hold all the supplements. You sometimes get patients go, oh, but I really want to take this one, and then you have to look into it. But for the most case, it's just easy to hold all the herbal supplements, over the counters, vitamins, minerals, all of that.
It is surprising how many people are taking zinc.
Oh my gosh, I know. All right, I think this is the last question. I agree with the question about people calling for the just in case. Can I have this just in case I get COVID? We strongly recommend against that in most, if not all situations, because the day you prescribe Paxlovid, it might be safe for your patient, but by the time they go to take it, they could have been prescribed something else, something medically could have changed that then makes it inappropriate and dangerous. So that's why we always recommend prescribing when they get COVID, not before they get COVID, because a lot of people get DVTs, PEs, have AF found to get started on anticoagulation. That's just one class, let alone, you know, all the other things that can happen to someone in you know, a very short time period. So I would recommend against that. I'm sorry, speaking on behalf of everyone, but I would recommend not doing that. Someone might have a different opinion.
Well, it's expressly stated in the PBS that it's not for.
Exactly, that's the other thing. It's PBS fraud, but.
Well, I was meaning that to kind of preempt that from a quality use of medicines perspective as well. And it's not only what could be prescribed. I mean, St John's Wort is one of the ones that are on the red list, and people could have gone out and chosen that for themselves.
Probably a good time to remind people about the safe disposal of medicines and encourage people to return all unused medicines to their local community pharmacy for safe disposal.
No, I think it's important as well, and particularly we haven't seen resistance yet, but I mean, we don't want these necessarily, inappropriately disposed of and contributing to resistance developing.
There's also Lauren one of the wonderful Dardis pharmacists has made a point in the Q&A about particularly for regional patients. There's obviously been a lot of really pragmatic use of and communication between community pharmacies and the hospitals. Not saying anything's been moved around against any kind of regulations, but there's a lot of good communication between sites. So if you're having trouble finding it, make sure you talk to your local regional hospital to see if you never know what might happen.
And good job on the last question, guys. D or E were very acceptable. You can obviously ask that they stop expressing for that time, but that is not always possible. So, and a lot of patients won't want to stop breastfeeding for that longer time either. So, but if they can absolutely do it. So D or E were correct in that question. And I think that's it for all my polls. Thanks for being so patient.
Oh, they're amazing polls, Cara. Absolutely amazing. All the feedback that we've got has been so positive, and I think I might have to call on you again sometime in the near future.
I'm always happy to come back. I just think people would be sick of me by now, but I'm always glad to be here.
Of course not. So much gratitude for your work, and the Jackie as well, to you as well, and Mel and Emily. It's been absolutely amazing. So, I hear all the feedback from our practice facilitators all the time saying that it was such a great webinar. So, thank you all.
Thank you, Brandon. I mean, again, a fantastic questions. This is really about how can we make this more practical and easy to understand, and certainly all these examples I think are really, really relevant. You've got the resources there that we've talked through. We'll send out the links, and then of course, as Deb was saying, there is that phone support through Dardis. We've got the support through the GP clinician advice line. We're here to support you and make sure that we can get patients access, and we do absolutely expect in the next week or two that we'll see increased availability, particularly of Paxlovid across community pharmacy as more sites are able to bring in stock. But a big thank you to everyone who's joined us tonight, and to our fabulous presenters, Jackie, Deb, Mel, Cara, and thank you, Brendan, as well, to Adelaide PHN and also Country SA PHN for supporting tonight's webinar. Thanks, everyone.